Hello students, in today's session let's briefly discuss about nephrolithiasis or the renal stones. So, by the word nephrolithiasis, we mean that there is stones in the excretory system of the kidney. So, it could be in the kidney, it could be in the ureter, it could be in the bladder and so on, that could be there. It has a prevalence in the Western world, almost 19% in men and around 9% in females you might get it. So, 19% in men and 9% in females, usually seen in 40 to 50 years. Highly increased chances with obesity, alcohol intake, dehydration are the ones. Large number of them can be asymptomatic unless they become obstructed. So, once there is an obstruction, then the pain would appear. So, based on that only the manifestation would happen. Majoritarily it can be considered as a lifestyle disease wherever you have a high salt intake, low fluid intake, obesity, etc. contributing to that. The problem with this is a recurrence chance. A stone, once it's formed, the chances of recurrence is almost 50% that is there, and you do find recurrent stones getting formed. So, what are the various pathogenetic mechanisms that have been proposed in the formation of the stone? So, the first is the supersaturation. So, the supersaturation of the urine resulting in the formation of the crystals. So, these variety of crystals are there, the important ones being the calcium oxalate, the calcium phosphate, the uric acid, cysteine, the struvite stone, the hydroxyapatite stones that is there. So, some of them have a genetic predisposition, some of them are acquired, some of them are secondary to various dietary risk factors. So, as you say, the risk factors would be a high oxalate, low fluid, high protein, high sodium, that could be an important risk factor. Low volume of the urine, which can help in crystallization, the low citrate content in the urine, as well as the high calcium and oxalate content in the urine. Conditions where there is a hypercalciuria or a cystinuria or primary hyperoxaluria are direct important genetic risk factors that are there, which can result in the formation of the stones. Lifestyle diseases, very common: obesity, alcoholism, decreased fluid intake, sedentary lifestyle and dehydration. So, these are all important risk factors that we encounter for the formation of the stones. As we say, the urinary risk factor is the lower the urine volume, higher the risk factor. So, higher the risk that is there. Higher the urinary calcium, higher the urinary oxalate and higher the urinary uric acid increases the risk. Low citrate, remember the citrate is a very important which inhibits the crystallization. So, the lower the citrate would be the higher risk for stone formation that you see there. The pH of the urine, the uric acid and the calcium phosphate stone are directly proportional to the lower pH that you could see. What's the common presentation? As I said, majority of them could be asymptomatic. You might find them only on an imaging, ultrasound done for something else, or a urine routine. When we examine, you might find certain hematuria, and when we go on to evaluate, that could be there. Otherwise, when they are acute presentation, you could get a sudden flank pain, with the hematuria and nausea as an important feature. Sudden flank pain with hematuria and nausea, and the pain might radiate from loin to groin, it might radiate to the labia or the testicle that's there. Sometimes the patients can come with a frank hematuria as a main pattern that you see. Various types of stone patterns are there. By far the most common is the calcium oxalate stone. It is associated with the hypercalciuria and a low citrate in the urine. The second most common is the calcium phosphate stones, associated with an alkaline pH and commonly associated with hyperparathyroidism, where you could get a nephrocalcinosis. The third type of stone which is common is the uric acid stone, which is seen when there is a low pH and in a patient with hyperuricemia or gout if they have it. The next type of stone is the struvite stone, which are nothing but the infection stones. Urease producing bacteria like the E. coli etc. are there. Rarely you could have the cysteine stones or the xanthine stones or the lysine stones can be seen. Associated medical conditions commonly associated with we see is obesity, diabetes, gout, hypertension, bowel disease and UTI. Again, based on the obstruction, if the upper urinary tract is getting obstructed, you can have a back pressure that's going on. These patients can come with pyelonephritis also. So, various investigations to diagnose. The simple one is an ultrasound abdomen, and then a urine routine can help you to diagnose it. Management strategies: small stones may spontaneously pass. You can give some NSAIDs, that's the important thing. Sometimes alpha blockers can also help. The surgical therapy is primarily as a endoscopic stroke wave lithotripsy or a ureteroscopic or a percutaneous nephrolithotomy can be done based on the size and the location of the stone. Stents may be required to be put, and then the stents may be removed later stage. Very importantly, if there is an acute infection or a renal failure, treat the infection, treat the renal failure, and you would want to take the surgical procedure at a little later date. Once you identify, it's very important for us to identify what type of stone and then institute certain preventive factors, because as I said, almost 50% of the stones have a very high chance of recurrence, and majority of the recurrences happen in the first 5 years. So you should make sure that the patient takes adequate fluid. So the fluid goal of more than 2 liters per day has to be met. Make sure the dietary changes. You take the decreased sodium, decreased oxalate and decreased animal protein that's there, and very importantly, lifestyle modifications, control of the blood pressure, control of the diabetes, avoidance of alcoholism, very important. Citrate supplementation can help. Allopurinol for the uric acid to decrease the uric acid. Thiazides for the calcium stones can also help. So these are specific things that can be done to prevent the recurrence of the stones. As we say, certain specific type of stones like the calcium stones, whichever we have, the oxalate stones, you can ask the patient to take thiazide diuretics if needed. Low sodium, low oxalate diet. If you look at the calcium phosphate stones, you control the pH and avoid alkalis. Do not allow the alkalis to go. The uric acid stone, you can use the xanthine oxidase inhibitors like allopurinol and alkalinize the urine. So make the pH more than 6.5. Struvite stones prevent infections and remove the stone, because this can act as an nidus and cause. Cysteine stones, what we do is urinary alkalization, and sometimes you might require chelation also for these patients. Long-term prevention, very important. Once the stone is there, make sure you identify the type of stone, make sure you identify the risk factors. Is there any treatable factors which has to be considered? You have to monitor these patients and educate them for good hydration, diet and adherence. Make sure that they avoid the urine frequently and do not avoid small volume urines. Make sure that the adequate fluid and dietary restrictions is followed on a long term so that they prevent the stone recurrence. Students, in today's session, we briefly discussed about the nephrolithiasis. We discussed about the type of stones, the risk factors, the clinical features and management.